Hello, I'm Dr. John Iskander. Welcome to CDC Beyond the Data. I'm here today with Dr. Janet Wright, Executive Director of the Million Hearts Program. Welcome, Dr. Wright.
Thank you so much. It's a joy to join you today.
For our audience, can you please remind us what the Million Hearts Program is?
Happy to, John. It's a national initiative co-led by CDC and CMS that's founded on the idea, really the groundbreaking idea, that if you took the assets and expertise of public health and combined it with the payment and policy that exist in healthcare and focused partners on a common goal, and you lit a timeline underneath it, that you could get a big goal done. And so the original Million Hearts launched in 2012 and was a 5-year initiative to prevent 1 million cardiovascular events, primarily heart attacks and strokes, over that 5-year period.
So we have some information now about what's been achieved in that first phase of Million Hearts. What have we learned from some of the studies that have been published?
Yeah, what we know is that progress was made. We also know that progress happens slowly. We will still be getting data on that 5-year period for about another 1.5 years. So final report on the number of events prevented will be available in 2019. But as all things true in science, we can make some predictions based on what's happened to date. We think that by the time 2019 rolls around, somewhere close to 500,000 events will have been prevented. The events are prevented when the risk factors are controlled. And what we know is that progress was made in blood pressure control, about 1% improvement per year. In cholesterol management, about 2% per year improvement was seen. Smoking prevalence did drop through all the work that's done by CDC, its partners, and really many organizations and entities around the country. But we didn't make any headway at all in sodium reduction, which has a huge impact on the numbers we're trying to control. So what I'd say in summary is not all the targets were met, so we predict we're going to fall short of the 1 million prevented.
Although still quite remarkable, 500,000 heart attacks and strokes prevented. Now, the Million Hearts Program, as we heard at today's session, is about to enter another 5-year phase. What can you tell us about who some of the targeted risk groups are for this program?
Well, and even before, what I'd say is that we learned a lot in that 5 years, and what we found is there was enormous engagement across the country by partners, whether they were involved in federal or state agencies, organizations, clinical ones and public health ones. And many of we did a round of interviews with people toward the end of Million Hearts during that last year and asked people, how are you doing with the work you have underway, really to gauge an interest in their desire to continue to pursue this as a goal. And we heard uniformly, we've just gotten our group together, or we've gotten our wheels rolling now, or we've set our targets. And so there was a great deal of enthusiasm about continuing the work. Our internal team, both at CDC and CMS, felt that we hadn't achieved our mission, but we did begin to move some of these slower wheels. One of the things we were most proud of is that millions of people were now covered by health systems that were measuring themselves by the ABCS measures, so aspirin, blood pressure, cholesterol, and smoking, just as one thing that happened on the clinical side. So as a result of understanding the depth of investment that many partners had made in this work, we did a new set of modeling exercises to make sure that we were focusing on the actions with the greatest impact, and we rolled that and the stakeholder input into a new design. That's called Million Hearts 2022. It kicked off in January of 2017, so we're now beginning the second year. And as you said, there's some new aspects. On the clinical side, we've added cardiac rehabilitation. Lots to talk about there, but it basically saves lives, improves health, and actually has a cost savings. Over on the public health side, we've added physical activity. And as you know, we wanted to add physical activity in the first 5 years. So we're really excited from the public health and community-based standpoint to add in those factors that will help people get and be more active.
So very ambitious. We know that progress has been made in preventing cardiovascular disease events, heart attacks and strokes, but that progress for some groups has stalled. Who are some of those groups that might be in some ways more at risk now?
Yes, in fact, it's the data that keeps me up at night, and that is that while we've seen a decrease in events and death rates in those who are 65 and older, we're actually seeing an increase in younger age groups. So if we look at data coming from the county level, 35 to 64-year-olds, from Maine to California, we are seeing an increase in death rates, not just event rates, but actual death rates from cardiovascular disease. We think that, and others, experts in the field, believe that this is the impact of decades of obesity and diabetes and physical activity, those things that are so interwoven, but now they're having an impact on actual event and death rates.
So many of those folks will have, access to primary health care in some form or another. And we saw a great presentation today. What have we learned about how to manage cardiac risk factors, and particularly blood pressure, in a clinic setting?
Yes, so I think especially the presentation today shows that it takes a team. It takes commitment at the highest levels in a practice or a system. It takes measurement, but not only measurement, it's actually analysis of the data. And the practice that we heard from today has gone so far as to share their data publicly. As it comes in, they just post how they're doing on those key measures of health. I think the other thing that we learned, or was reinforced by today's presentation, is that developing health, cardiovascular health, and preventing events starts at home and in the community. So the things you heard from Leslie Meehan about how a community can be structured to help people naturally become more physically active, safely, affordably. I think what they're doing in Tennessee, we hope to see scaled and spread across the country.
Yes, certainly from Leslie's presentation, we saw, I thought, a lot of things come together that we've been hearing about for a while. The idea of an exercise prescription, the idea that healthcare has to go beyond just the healthcare sector. Yeah, I thought there was a lot of great information there. So for those in our audience, whether they're clinicians, whether they're public health professionals, whether they're students of public health medicine or nursing, where can they go to find the resources to understand, what they can do to help prevent even more heart attacks and strokes?
Yes, thanks for that question, John. There's certainly information available on the Million Hearts website, but I think in the departments of health across the country, there are tremendous resources. It's almost like a matchmaking game to ask clinicians to date their public health experts in their communities and in their states, and likewise for the public health experts across the country to get to know the clinicians in their environment. Because while tools and resources and things you can hold in your hand or download from the internet are extremely helpful, it is the relationships between these two types of experts. We don't need them to do what the other person does. We need them to do what they do best, but to do it in communion. And that's how I think we're going to actually see improvements in health. And we're going to take that curve of the 35 to 64-year-olds and flex it down again.
Well, thank you very much for joining us today, Dr. Wright.
My pleasure. Thank you.
Please join us for our next session of Beyond the Data.
Noise is all around you. It occurs at all times, day and night. Sound that's 85 decibels or higher can cause hearing loss. You may need to protect your ears from loud sounds you hear throughout the day, and here's why. You wake up using your phone as an alarm, and that's fine because it doesn't last too long. Taking a shower isn't too loud for your ears. Making a smoothie, getting louder. As long as you don't yell,
This is really good.
this is totally fine. But if the daughter is listening to loud music, turn down the volume. Vacuum on, but not too long. Getting loud. Use earplugs or noise-canceling headphones. Please don't rev the bike. This is fun, but it's a little loud. Enjoy your music, but lower the volume. Yikes! Good thing your windows are up. Getting loud and louder. Move away from the speakers and use earplugs. Enjoy your exercise class, but you need to bring earplugs with you. The music can be loud. Move away from the speakers. Use earplugs. Even the band is wearing them. You're tired at the end of the day, so you rest and recover. So must your ears. Research suggests a 16-hour rest period following prolonged exposure to noise, so it's important to protect your hearing. Turn the volume down. Plug or cover your ears and move away from the loud noise. Take breaks from the noise. When you find yourself in noisy environments, be sure to use earplugs or noise-canceling headphones to protect your hearing so that you can enjoy these activities. Remember, loud noise can cause hearing loss, and once it's gone, you can't get it back. Learn more at the website.
Did You Know video series from the National Cancer Institute, Rare Cancers. Did you know that there are more than 500 types of rare cancers? Rare cancers are defined as those cancers for which there are fewer than 40,000 new cases per year in the United States. Combined, all rare cancers account for slightly more than 1 out of every 4 cancer diagnoses each year, and 1 out of every 4 cancer-related deaths. Rare cancers can affect any part of the body. Examples of rare cancers include anal, stomach, and laryngeal cancers. Anal cancer represents 0.5% of all new cancer cases in the U.S. It is slightly more common among women than men. Infection with the human papillomavirus, also known as HPV, has been found to cause most cases of this cancer. Stomach cancer represents 1.6% of all new cancer cases in the U.S. It is more common among men than women, and among other races and ethnicities than non-Hispanic whites. Age, a diet rich in certain foods, and some medical conditions can increase the risk of developing stomach cancer. One of those conditions is infection of the stomach with the bacterium Helicobacter pylori. Laryngeal cancer represents 0.8% of all new cancer cases in the U.S. It becomes more common at older ages and occurs more often in men than in women. Smoking is a major risk factor. 5-year survival measures the percentage of people in a study or treatment group who have not died of their cancer 5 years after their diagnosis. For many rare cancers, including esophageal, myeloma, and brain cancer, 5-year survival has improved since 1975. Research and new treatments for rare cancers have helped improve survival rates. The National Cancer Institute conducts research and provides research funding to institutions across the nation to better understand rare cancers and find treatments and cures for them. To learn more about clinical trials and available treatment options for rare cancers, visit trials.cancer.gov. The NIH Genetic and Rare Diseases Information Center, or GARD, provides the public with current, reliable, and easy-to-understand information about rare cancers and other rare diseases in English and Spanish. Visit rarediseases.info.nih.gov for more information or to contact a GARD specialist by phone. For more cancer statistics, go to seer.cancer.gov. U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute. Produced February 2018.
During an emergency, veterans should immediately seek care at the nearest medical facility. An emergency is an injury, illness, or symptom so severe that without immediate treatment, a veteran's life or health is in danger. In this situation, veterans should call 911 or go to the nearest emergency room right away. Veterans do not need to check with VA before calling for an ambulance or going to the ER, and they should never delay emergency medical care in order to receive care at VA instead. Veterans may have questions about how VA's payment process for emergency care works. In general, VA can pay for emergency medical care at a local ER for a veteran's service-connected condition, or if the care is related to a service-connected condition. For example, let's say a veteran is experiencing chest pain and goes to a local ER. If the chest pain is related to a service-connected condition, VA can pay for the care based on Medicare rates. If the chest pain is not related to a service-connected condition, VA can still pay for the care at a local ER, but there are three main requirements. First, how much VA can pay depends on whether the veteran has health insurance. If the veteran has health insurance, VA can pay only after the health insurer or other liable third party has paid or denied the claim, and only after the veteran has made any required health insurance co-payments, cost shares, and deductibles. If the veteran does not have health insurance, VA can pay for the care, which is generally capped at 70% of Medicare rates. Second, at the time of the emergency, a VA medical facility or other federal facilities were not reasonably available, or it wasn't reasonable to find this out. Third, at the time of the emergency, the veteran was enrolled in VA healthcare and had received medical services through VA within the last 24 months. Taken together, these are the main requirements that must be met before VA can pay for emergency medical care at a local ER. After a veteran has received emergency care, the nearest VA medical facility should be contacted within 72 hours. VA will help coordinate additional care and arrange payment as applicable. Once a claim is received, VA may conduct a clinical review to make sure VA can pay for the emergency care. Even with these requirements, veterans should always seek care at the nearest medical facility during a medical emergency and never delay emergency care in order to receive care at VA instead. Visit our website to review the full requirements for receiving VA payments for emergency care and how to submit a claim. You can also contact 877-466-7124 for assistance.
Welcome to Beyond the Data. I'm Dr. Phoebe Thorpe, and here with me today is Dr. Brian King from CDC's Office of Smoking and Health. Thank you for joining us, Brian.
Thanks for having me.
The session today was on e-cigarettes. Very interesting. I was very surprised at the number of problems there are with e-cigarettes, especially regarding people's health. Can you tell me some of them for our audience?
There's still a lot we don't know about e-cigarettes. These products came to the United States around 2007, and they're currently unregulated at the federal level. So there's still a lot we don't know about what the ingredients of these products are or what the long-term health effects are. But we do know enough to say that they are dangerous for youth, and that youth shouldn't be using any form of tobacco product, irrespective of whether it's electronic, combustible, or a smokeless tobacco product. And one of the common ingredients in all of these products, including e-cigarettes, is nicotine, which we know is not risk-free. Outside from being highly addictive, it can also harm the developing adolescent brain and also lead to fetal toxicity among pregnant women. So the nicotine is a concern in these products for these populations, youth and pregnant women. But there's also other ingredients that have been identified in e-cigarettes that could potentially be harmful to people, including ultrafine particulate matter, volatile organic compounds, and other potentially dangerous ingredients.
And those, the ultrafine particulate matter, those are all in the aerosols, so it's not just water vapor that you're breathing in.
Yes, that's really important to note that it's not harmless water vapor, and it's actually an aerosol that can contain harmful and potentially harmful ingredients. And since the products aren't regulated, it can vary from product to product.
And one of the things that I had heard today that I actually found quite alarming was the mention of the flavorings. One of the flavorings is associated with bronchiolitis obliterans, which is a big word for permanent scarring of the airways of your lungs. That means so permanent, and the airways of your lungs, you'd have difficulty breathing. What else is known about the flavorings that they're adding to the e-cigarettes?
So there's a large diversity of products currently on the marketplace. There's over 450 brands and thousands of flavors. And users can even create their own flavors if they go to vape shops. But what we're seeing is an emerging body of evidence demonstrating that there are some potentially harmful flavors that are being used. And it's also important to remember that some of these flavors, although they may be recognized as safe for ingestion, for people to ingest in food, we don't know what the health effects are for inhalation. And that's how people use e-cigarettes. They inhale the product into their lungs. And so there's concern that some of these flavorings in particular can really harm the lungs, particularly among vulnerable populations.
And coming back to the vulnerable populations, you briefly mentioned youth. Tell me again, what is it we're so worried about with youth?
So with youth, one of the primary concerns is the inclusion of nicotine in these products. And the 2014 50th anniversary Surgeon General's report was clear that there's potential for nicotine to harm the developing adolescent brain. And in addition to harming the brain, we also know that nicotine is highly addictive. And so it could potentially lead youth to a lifetime of nicotine and tobacco addiction.
What have we learned about tobacco that we could use with the e-cigarettes as far as concerning controlling and use?
So there's a strong evidence base from several decades, 50 years of tobacco prevention and control interventions, and we really know what works to effectively prevent tobacco use. And e-cigarettes can be included in a lot of those interventions, the most notable of which is youth access restrictions. We know that it's dangerous for youth to use these products, and that interventions to restrict the sale and access can reduce youth use of these products. There's currently several states across the United States where it's still legal for youth to walk into a mall kiosk or a convenience store and legally purchase these products. And there's also widespread internet sales as well. So youth restrictions are really a key lever to prevent youth access. Another is including e-cigarettes in clean indoor air restrictions, where conventional cigarette smoking is otherwise prohibited. And this helps to maintain a clean indoor air standard so that we can prevent exposure of non-users, particularly kids and pregnant women, from exposure to the aerosol from these products.
And those are both things that are regulated at the state level of the age that the nicotine and e-cigarettes would be available and the indoor air. Some of the other things that we mentioned today was just knowing yourself as a parent or as a clinician what the risks are so that you could speak to somebody about what they might not know. What are some of the other things that could be done beyond the things that we've mentioned so far to make people more aware of the risks of e-cigarettes?
So I think it comes down a lot to education, particularly parents and clinicians on the individual level can become educated about the potential harms of e-cigarettes among kids, because we know that most adult tobacco users begin before the age of 18. So if we can implement interventions to prevent them from starting before the age of 18, we could potentially prevent them from a lifetime of nicotine and tobacco use. And the same would go for e-cigarettes. And so at the individual level, education is really key, but we can't underscore enough the importance of population interventions, which we know work to effectively reduce tobacco use and help denormalize these products among youth and young adults across the broader population level.
And do you have some examples of that? I was wondering, we had at the end of the session a great presentation about mass media and hard-hitting campaigns. Can you speak a little bit to that?
Yeah, so we know that emotionally evocative, hard-hitting mass media campaigns are a very effective mechanism to educate people about the adverse health effects of tobacco use. CDC's Tips from Former Smokers is a prime example of a campaign that's been implemented since 2012 to educate people about the adverse health effects of smoking from former smokers themselves who have experienced adverse health effects. Currently, there's no broad-based mass media campaigns to address the issue of e-cigarette use focused on youth and young adults and the potential harms, but it still speaks to the importance of education, that it's important to reach out to youth and to counter some of the messaging, because e-cigarettes are advertised heavily via television, for which conventional cigarette advertising has been banned in this country since the early 1970s. So there's definitely pro-marketing influences for e-cigarettes in multiple different media, and it's important to counter that message for youth and young adults so they understand the harms of using e-cigarettes and what that impact is in their long-term health.
Yeah. So if somebody was interested in finding out more about e-cigarettes and tobacco, where would you tell them to go?
They can go to CDC's tobacco website, which is www.cdc.gov/tobacco. And that has several resources on proven tobacco control interventions, as well as information on e-cigarette use and interventions and educational materials.
Sounds like a great place to go to find out more. Yeah. Thank you so much for joining us.
Thanks for having me.
And thank you for joining us. See you next time for Beyond the Data.
VA is committed to supporting veterans who have service-connected conditions that result in infertility. VA offers a range of services to treat infertility, including in vitro fertilization, or IVF, for eligible veterans and their spouses. To be eligible for IVF treatment, veterans must have a service-connected disability that results in the veteran being unable to procreate without the use of fertility treatment. For an initial evaluation, veterans can schedule an appointment with a VA provider or call the Women Veterans Call Center at 855-829-6636. This evaluation may be performed by a VA primary care provider, a VA urologist, or a VA gynecologist when available. Based on the evaluation, VA refers eligible veterans to infertility specialists in the community, who include reproductive endocrinology and infertility, or REI providers. These providers work with veterans and their spouses to develop a treatment plan. Treatment may include several types of services. VA covers infertility assessments, counseling, and certain treatments, including hormonal therapies, surgical correction, artificial insemination, and IVF. VA covers up to 3 IVF treatment cycles. These services are provided by VA through its Community Care Network, a group of outside community providers who contract with VA to provide care to veterans. To learn more about treatment for service-connected infertility, veterans can contact the Women Veterans Call Center at 855-829-6636. Community providers who are interested in providing REI services to veterans can go to our website to find out how to partner with VA.